So we have got a new case here, who is an 85-year-old gentleman who have background of hypertension and hyperlipidemia. He presented in 2016 because of anemia. And for part of the anemic workup, OGD was done, which shows a bleeding ampullary nodule. Colonoscopy as part of the anemic workup was unremarkable except of a small sigmoid polyp. EUS of the ampullary nodule shows a 1 centimeter polypoid lesion at the major papilla with no major invasion, and there were no periduodenal lymph nodes. Polypectomy of the ampullary lesion was performed in March that year, which the histology showed granulation tissue. The patient's hemoglobin was back to normal. However, he presented to us with recurrent anemia again in October this year, with hemoglobin dropped from 14.1 to 11.4. OGD was repeated, which shows 1.2 centimeter sessile lesions involving the major papilla. Biopsy shows inflamed granulation tissue with no malignant cells seen. This is the photo of the lesion. And today we're going to do EUS plus endoscopic ampullectomy.
Camera, have you heard the case?
Yes.
Yes.
And now we have the endoscopic image, and it looks like an inflammatory polyp kind of coming off the
Right. So
lateral or inferior
you're exactly
aspect.
right, Uzma. You can see this is an ERCP scope, so I can't show you a near focus and all the fancy things that my Japanese colleagues do. But you can see here clearly there's no sulci pattern. This is an inflammatory polyp. What I was doing was just I wanted to understand where the ampullary orifice was relative to this lesion. And you can see here I have a ball tip catheter, which is my instrument of choice for patients with ampullary lesions, just because it doesn't cause any trauma. And I'm obviously up way within a duct of some kind, and you can see that the orifice is sort of beside the inflammatory lesion. The plan, Uzma, was actually to do EUS, and it wasn't because I think that the EUS is going to be so important in terms of knowing whether this is invasive or not, because obviously it's a benign lesion, but it did give me an opportunity to show people the technique, at least that I advocate for imaging the ampulla, to sort of follow up on Dongwang Sio's talk on staging. But the reason for doing this is I was just contemplating the way that I'm going to remove this. And do I need to do just sort of a full ampulectomy just in order to get the whole thing out? Or could I put in, for instance, a pancreatic stent? And then just go beside the stent with a snare, because again, this is it's an inflammatory lesion, so it's not like I have to get an en bloc resection. So these things are just going through my mind here as I'm sort of contemplating what to do.
I actually had a patient just
So,
like this last month, and I ended up just leaving.
If you have time to stick with me, I did want to do an EUS on this patient. I'm sorry?
To see the distal part of the CBD?
Well, again, it's a benign lesion,
Yeah.
so I don't expect there to be any invasiveness. I don't think the bile duct will be dilated or anything. But before, as I went down, I don't know if you saw it, Uzma, but there was almost a fish mouth. It made me think a little bit of IPMN. But the main thing was I wanted to show my technique for imaging the ampulla.
Rob, I was.
And
Can you hear me? Hello? Oh, can you hear me?
Can you hear me?
Yes,
Yeah, I can hear you,
me?
Uzma.
Okay. I was just saying that I had a similar case last month where it was more of just an inflammatory polyp kind of alongside the pancreatic duct orifice. So I ended up just putting a pancreatic duct stent and snaring off the polyp.
Did you just snare off the polyp, or did you do a full ampulectomy?
I didn't do a full ampulectomy since it was a benign inflammatory polyp.
Okay.
Which is what I was thinking, that perhaps you don't need to do the full ampulectomy. But again, we'll see what your EUS shows too.
Yeah, so that's sort of what I'm contemplating. The only thing is that Raymond and his team, when the lesion was much smaller, did do a local resection, and now it's reoccurred. He's 85 years old, so it would be nice to try to sort of get rid of this problem altogether. Are we having?
Yes, go.
Should we do a formal ampullectomy or should we do a polypectomy?
Well, see, that's what I'm thinking about.
But this is because the nature is benign. I think inflammatory region is not neoplastic one generally.
Yeah.
So better to remove the just polypoid part. Huh? But later it can grow again.
Yes.
2 years ago, Raymond actually did a small polypectomy at the ampullary orifice area. But interestingly, now after 2 years, the size became much bigger.
Just a little bit.
Maybe initially they resected just part of the polyp, but I'm not sure.
Maybe a little bit more.
And Rob,
So-
you're going to use a linear or radial scope.
Okay,
for your
so
staging.
they need to sedate him a little bit more. We're under conscious sedation in this room. We don't have any anesthesia, so give me a little bit of time here. So this is my technique for imaging the ampulla, specifically for imaging the ampulla. Number one, in the United States, I will give glucagon. Here in Hong Kong, they have buscopan. So I paralyze the duodenum. And then I, in my own unit, have a pump to pump water in through the biopsy channel. You can either use syringes or a pump. If you use a pump, then you need to turn the volume down because you don't want to get a lot of turbulence and microbubbles. So I paralyze the duodenum. I fill the duodenum with water. I go down with a radial scope. I position myself just barely distal to the ampulla. And then what I do is I first look at the endoscopic image, and I go up on my up-down to what I call kiss the papilla. So once I've got that maneuver down, then I look to the ultrasound image, and when I come up on the up-down, where does that go on the ultrasound image? Usually it goes to 6 o'clock. So then I know I can focus my eyes as I slowly withdraw the instrument. I can focus it at 6 o'clock, and then I'm looking for the insertion of the pancreatic duct and the bile duct for the ampulla.
Yeah. But sometimes when we inject, the patient position is actually left lateral decubitus, and the duodenum is upper part of the body at this position. So frequently it flows downward or flows backward to the gastric antrum. Then do you inject a little more or any other your trick?
So I've not had trouble. I usually do it in the left lateral position, and I don't have trouble. I, prefer the patients in this circumstance to be intubated. I do worry about too much water in there and so forth, but I generally don't have too much of a problem filling the duodenum. So there you can see the lesion, Uzma. I hope you can see the lesion. I've asked to give a little bit of buscopan to paralyze the duodenum. And now if I could have some water, either syringes or a pump.
Pump.
Okay.
They
And
prepare
the pump volume is what? Is it low? Okay, pretty low. Okay. So
while you're getting the position, maybe we'll check out the ESD case next door. We'll be back to you.
Okay. Okay. Welcome back. So you should have picture on picture, and you can see on the endoscopic view there is the papilla at the 12 o'clock. So I first go up on my up-down, look endoscopically. I go up on my up-down, and I'm kissing the papilla with the upward movement. So now, turn your eyes to the ultrasound image, and when I go up on the up-down, you can see it goes to 6 o'clock. Do you see that?
Yes.
Can you hear me?
Yes, we
Yes.
can hear you.
Yes.
We see
Okay.
it. We can
So
hear
now
you.
that I've got my orientation, if you want, you can concentrate just on the bottom screen. Okay? And now I'm going to fill the duodenum with water. A few bubbles here, which we need to get cleared. Okay, so now the duodenum is sort of filled with water. It's a little bit of turbulence. I didn't really want that. But now I'm going to come up on my up-down just a little bit and pull back.
I think we're starting to see the lesion
Freeze
there.
it. Freeze it. Okay, so here is the lesion itself. Okay, you can see the lesion itself is here. Here's the duodenal wall. Okay, so if this were potentially a malignant lesion, then we would be looking at this duodenal wall to see if the duodenal wall was bridged. Thank you. So there's the lesion itself underneath the arrow.
The
Right,
wall
perfect,
looks
thank you.
pretty intact at this point.
There's a very intact duodenal wall. I'm going to pull back a little bit further. Pulling back just a little bit further. A little bit further. Freeze it. Okay, so here is the pancreatic duct taking off here, Uzma. Unfreeze. So I pushed in just a little bit. There's the lesion. Pull back just a little bit. And right there is the pancreatic duct taking off. Do you see that?
Yep.
And then there to the left is the bile duct. Okay? So that's the way, and the pancreatic parenchyma looks completely normal here. So again, that's the technique to use. I don't see any dilation of the pancreatic duct, no dilation of the bile duct. They look normal, which is appropriate. But that's the technique you should use. Paralyze the duodenum, fill it with water, and then concentrate on the area of the lesion. There it is. Dong Wong is showing it to you. And then slowly pull back, and then just go back and forth and look at the freeze it. You can sort of see the duodenal wall here is completely normal coming under this lesion. And then as the pancreatic duct emerges right there, as the bile duct emerges right there, this is the opportune time to assess whether there is invasion into either of those ducts. Again, I wasn't expecting it given the lesion, but I just wanted to show my technique at least for imaging the ampulla.
No, and I think that
So if
was
you guys
a great
wanna,
teaching example.
Go to another, I'll answer questions, or you can go to another room. I'm going to switch back to the ERCP scope, and then we have to make a decision. I'm leaning toward placing a pancreatic stent and then doing a snare resection without doing an ampulectomy, but it'll be open for some discussion.
Hello.
Okay, so just to show you this lesion, I'm looking at it even more carefully now. I'm going to toss this aside, and you can see it's actually on top of the ampulla. It's almost pedunculated and on top of the ampulla itself. So we've decided, just because of the proximity to the ampullary orifice, we decided that we would put in a pancreatic stent. And my initial cannulation here has been in the bile duct. It's sort of a patulous opening, and I've basically not been able to get into the pancreas yet. Okay, fluoro. Oh, sorry. Yeah.
Oh,
It's actually a good
doctor.
teaching point, Rob, that
Okay, so that's
anytime
pancreas.
I apply any
Okay,
kind of thermal
so
energy
wire in slowly.
to the ampullary
Fluoro?
region, you do always think about
there you go. Okay.
Okay.
pancreatic
That's
duct stenting to protect
So
it.
Okay.
there we are in the. That's enough. That's enough. So just inject just a little bit there.
Mhm.
Okay. Good. Okay.
So in my case, if I want to use a fluoro image also, I generally start with
Okay. Ready?
semi-prone position, but
Ready?
because we don't have C-arm moving around, but This room is equipped with fancy fluoro machine, and even though patient position is left lateral decubitus, the C-arm can get a beautiful image by rotating the angles. You have this C-arm in your unit, right?
So yes, we have fixed sort of C-arms in all of our interventional rooms, 3 out of the 5 rooms that we have, yeah. So what we've chosen to do, it's a 5 French stent. It's 7 centimeters long. It's got a flap on the end of it. So Raymond and his team will have to come back and remove the
During my talk about ampullectomy, and I mentioned that the size, whether it is really matters. Previously, they mentioned that 2 cm or 2.5 cm is the optimal indication for endoscopic therapy. If there is bigger one, if we try to do ampulectomy, then they say that there is higher risk of developing complications such as bleeding and pancreatitis, sometimes perforation. But nowadays, I think more and more endoscopists are doing bigger one ampulectomy. So during my talk, I mentioned up to 5 cm. Do you agree with that? Or
yeah, but I don't know that there's a limit in size. I've certainly removed them up to 5 centimeters. Sometimes I'll do that in a piecemeal fashion. Obviously, there can be lateral spread, which can be managed as well. I think the main thing for me is that the bigger the polyp, probably the greater the chance there is of cancer within it. So you have to be aware of that.
Sometimes we found a focal cancer area after ampulectomy. Before, even though we did several biopsies, just the adenomatous tissue came. Yep. But after ampulectomy, we can see some focal cancer area. In that case, do you advocate surgery?
Yes.
Or
if I have a suspicion or I can confirm surgery on a biopsy with Rose, then I think those patients should go to surgery.
Surgery, yes.
Okay, so I'm going to fluoro here.
We'll be back briefly. We just
okay, I'm just going to place this pancreatic stent, and then I'll wait for you to do the resection.
Can we go to room 4?
Okay, Uzma,
Yes,
are you there?
Yes, I'm very excited to see this.
You're very excited about this?
We've been waiting.
Okay, so I'm just tossing this thing around one more time. There's the stent in place. I'm just sort of trying to decide my strategy here. So I've got a 1 centimeter snare, so I'll go ahead and open. All the way? All the way open, okay. Sorry, let me get rid of them. Okay. So I can try this maneuver first. This is similar to an ampulectomy where we embed it up top. Okay, slowly close. Okay, stop. Now I'll just assess where I'm at.
Looks like you got it.
And I'm actually fairly happy with that. I'm close to the pancreas, but I think I'm okay there. A mention was made, I think, by Raymond about whether I should take a little bit more of a margin since they removed it and it reoccurred. Obviously, I don't want to do an ampulectomy. I just want to take off this polyp. So I think I'm pretty happy with this. So if this was an ampulectomy, Uzma, my technique is to put the snare down exactly as Dongwon described it, and then I close the snare completely. It's completely closed for my ampulectomy. In this particular case, it's a little bit different. So I don't want a really, really incredibly tight closure. And I'm actually a little bit prone to use just sort of coagulation current to cut through this because I think it's pretty narrow. I don't think I need the robustness of an endo cut. So I think I'm going to come through this, medium, not super fast, but not super, super slow. And then finally, Uzma, we've talked about the strategy for retrieving this the specimen. We're going to open the snare. We're prepared to suction. I have a suction trap on. It may be too big for that, but always discuss with your assistant what the strategy is for grabbing the specimen. So here we go. Let's.
Can you
Come
remind
through.
us, did you inject and raise the lesion
Open?
before
No,
this?
we
No.
usually don't at the ampulla because the polyp usually gets tethered
Close
down
a little
by
bit.
the bile duct and pancreatic
Close.
duct. So it won't
Stop.
fit.
Okay.
Very nice.
Wow.
Okay, so there's the resection.
Very nice.
Uzma. So,
Caught it too, right away. And actually now looking at your resection site, I mean, I think it was a great choice to put the pancreatic duct stent in because you
it's a
got
little bit.
pretty
It's
close.
a little bit close there, isn't it?
Yeah.
Yeah. Yeah.
Wow,
Okay,
that's a
so
really
I
nice
think
resection.
even though he is he's only got moderate sedation, I think I'm going to go ahead and pull this specimen out, Uzma. I sort of want to make sure I have it. Ah, there we go. Okay.
We have it.
So Dr. Hawes, what would be your surveillance plan for this patient?
Yeah, so I sort of liken this patient, I don't know about Uzma, the rest of your practices, but I see a fair number of patients with gastric polyps that present with anemia. And I just follow them in terms of their hemoglobin. If this patient presents with anemia, he responded well to the initial resection, and then he redeveloped his anemia. That's what prompted Raymond to restudy him. So I don't know that this needs surveillance in the sense of, okay, every 6 months, every year or whatever to relook. I would probably just monitor his anemia. But
Prof, that was
He
beautifully done.
just needs his x-ray in 2 weeks, though, to check for the PD stent. But it probably won't migrate because of the flange, so I guess he'll get one more endoscopy.
he's going to get an endoscopy from the team just to take out this stent,
I agree after
Uzma.
that,
So,
probably he doesn't need any surveillance.
but that should be fairly soon. I don't like to leave these stents in for very long. So,
All right, thank you.
Thank you very much. That was a beautiful
That was great.
demonstration. Yep.
okay. All right. Thank you.
Yep. So can we go to room 4?